Abhay, we are live. You can start.
Okay. Sir, am I audible, sir?
Yes,
Yes,
yes, you are
yes.
audible.
Okay. Good afternoon to everyone. I, Dr. Abhay Pratap Pandey, on behalf of the organizing committee, welcome once again to you all in 2-week refresher course on statistics, the application of statistical tool in real world. Today, we have a very well-known personality in statistics and clinical epidemiology and biostatistics, Professor Girdhar Gopal Agrawal, sir. So it gives me immense pleasure to welcome respected Professor Gigi Agrawal, sir. Before I invite Professor Gigi Agrawal, sir, to deliver his talk and engage with you over the next 1.5 hours on clinical epidemiology and biostatistics, I want to give a brief about him. First of all, a very good afternoon, sir, and thank you so much, sir, for accepting our invitation at such a difficult time. Professor Gigi Agrawal, sir, is an ex-professor of the Department of Statistics, Lucknow University. Sir has completed his master degree from Lucknow University. He has completed his MS and doctorate in mathematical statistics from Purdue University, USA. Sir has started his academic career in 1973 as a teaching assistant at the Purdue University, USA, and Sir has also been a former assistant professor at Miami University, USA. Sir has also served as a visiting fellow at ISI Kolkata, and he had joined Lucknow University in 1980 as an assistant professor. Importantly, in 1995, when Sir was working as an associate professor, Sir decided to earn one more expertise and completed MSc in clinical epidemiology and biostatistics at McMaster University, Canada. Currently, Sir is working as guest faculty at Lucknow University and a faculty member in the Institute of Clinical Epidemiology, King George Medical College, Lucknow. And Sir is working there since 1994 to till now. Sir is devoting 18 to 20 hours per week to clinical epidemiology unit. Sir is guiding MD and MS student in their thesis work and guiding in data collection, designing, and data analysis of research project and taking lecture on biostatistics and MPhil PhD program. Sir is also the recipient of the several prestigious award and fellowships. Name of you are Biostatistics Fellowship in the International Clinical Epidemiology Program at McMaster University, David Rose Fellowship at Purdue University, Indian Council of Agriculture Research Fellowship, Junior Research Fellowship, Visiting Research Fellowship, and many more. Sir is a member of various national and international statistical societies and has been a member of multiple committees. His research area in mathematical statistics and clinical epidemiology. Sir has reviewed many books on different topics of statistics. Sir has published more than 120 research articles in various reputed national and international journals. Sir is also an editor, associate editor, and reviewer in the various national and international journal of statistics and medical sciences. Sir has also been supervised more than 20 research students in PhD and MD. Sir has completed more than 20 research projects funded by various national and international bodies. And currently, sir is also working on the various field like research work on the medical field and in pure statistics. So now I would like to invite Professor Gigi Agrawal, sir, to deliver his talk. And thank you so much, sir, for accepting our invitation and gives your valuable time, sir. Thank you so much, sir.
Thank you for Abhay and Ashish. And you have said too much about me. That's all right. But let me try to share the screen now. Hello. Hello,
Yes, sir.
Yes, sir.
You are
Yes, sir.
audible, sir.
can you see the, I am unable to start this, I mean, slides. What is the problem? Yesterday it was all right. Can you see the slide?
Yes, yes, sir.
Yes,
Yes, sir.
yes,
We
it is
can see,
visible.
sir.
But it is not come in the mode. appearance.
Sir, just click F5.
Eh?
F5. Just click F5.
F5.
Yeah. Maybe it is full screen. No. Sir, say again, please.
But it is not increasing. Why? Yesterday I did practice with him.
Okay.
Huh?
So what's an issue?
So try to slide show in the starting
Hmm?
upper bar. Slide show from beginning in the topmost left corner.
Yeah.
Left corner. Left corner.
This slideshow.
Yeah.
Yes, sir. Slide show and then from beginning.
Sir, click on the slideshow.
Yeah, I am clicking, but it is not.
It's not clicking. Okay.
You can do one refresher 1 to 2 times.
Hmm?
So refresh the system once again.
This is the slideshow option over the in the bottom also.
This, na?
This one, huh? This one, sir.
Yes, sir. Yes.
Not
Yeah,
clicking.
I am trying to click this.
Yes.
Sir, first you open this PPT in your laptop and click on the slideshow. Then you share the screen.
Okay. हाँ यही problem है sir. पहले open कर.
Eh?
Just open the
Sir.
just open the PPT in your system.
Yes, sir. First, open your PPT file, then share your PPT file on Zoom platform.
Can you see now?
No, sir. Just share the
Uh,
screen. Now share
Ashish
the
sir.
screen. Yes.
एक मिनट sir, actually first open your PPT, then after minimize that, then share the screen.
Yeah, I have done that.
Okay.
Okay.
I have opened this file,
Yes.
and file is open, and then it is showing in the share one.
Then you share the screen. I think you are trying to show only the PPT. Try the screen, then click on the that minimize option.
I have opened the slide. I have minimized it.
Okay. Then share screen.
Yes, sir. Is it visible, sir?
Okay now.
Yes,
Yes,
sir.
sir.
Is it okay,
Yes,
sir?
sir.
Okay.
Yes.
Sorry for that delay.
No issue. No issue.
No
All
problem. It's okay, sir.
Good afternoon to all of the persons present here and on YouTube, whatever. Well, as you know that I myself is a hardcore statistician, and of course this talk is not meant for mathematical statistician actually. Although my original PhD degree was in mathematical statistics on spline functions, so that was more close to mathematics than statistics actually. Then I, in 1994, as I have told, I got an opportunity to go to McMaster as a trainee, actually, in this program of clinical epidemiology network, which was started that time. So I got an opportunity to go there. So I took a U-turn from there, actually. And at McMaster, I went then, and when I talked to doctors, then I realized that they are the one actually who are using really statistics. The one which I was doing, actually, I was just teaching mathematical statistics, Kramarov theorem, and their proof and all those things. But when I talk to doctors there, then I say that how, whether statistics can be in this form actually. Then I realized then, and so it took a while to get used to those things. And since then I'm working with these doctors. And so this talk, actually, I have talked to make very elementary one, so that terminology which I use may not be acceptable to hardcore statisticians, the definitions very rude, but that these definitions are acceptable to doctors so that I can talk to them. So I, in real sense, that I main thing as is the theme of this your refresher course. So I think my talk will fit into that, actually. And one thing I want to tell you, that when I talk to my friends and some relatives, that I go to these medical colleges here and there and go to doctors, then they were saying that what do you do with those doctors? Well, I said that you have to, I think you should attend this talk, then I can justify my going to those medical colleges. Anyway, I started with this example. So Mr. Gupta is a 50-year-old man with a recent history of myocardial infarction, has arteriocortical X-ray evidence of severe occlusion of 2 of his 3 major coronary arteries. So the question is, should his physician prescribe drug treatment or refer him to a surgeon for a bypass surgery? Well, the traditional clinical approach to this question will be based on pathophysiologic and pharmacologic reasoning, as well as the clinician's familiarity with the individual patients. That is a history of the individual patient, about morbidity and all those things. But now, from epidemiological thinking differs conceptually from this clinical thinking. Epidemiology can be defined as the study of disease and other health-related phenomena in groups of persons, and the word derives from the Greek upon and demo pupil. So epidemiology thinks in terms of group. So here, that physician is thinking just about one individual, but epidemiologists think in terms of the groups, not individuals, and ask whether a group of patients with demographic, clinical, and psychosocial characteristics similar to Mr. Gupta will fare better on average if they receive medical or surgical therapy. So instead of answering the questions for one individual, epidemiology tries to handle the same thing for a group of patients. So now, if 80% of patients like Mr. Gupta have been shown to improve with surgery versus 60% medical therapy, the epidemiologists would have no trouble in advocating surgery for Mr. Gupta. Well, in an individual approach, Mr. Gupta's physician, however, may find it difficult to recommend a course of therapy that may not be unequally best for his patient. Well, the essential compatibility and mutual benefit of these two approaches have given rise to the term clinical epidemiology, actually. So this marriage of the epidemiological and individual clinical approach is proving fruitful, not only to patients, their caretaker and researchers, but also to disciplines themselves. So inferences based on statistical associations can lead to new avenues of laboratory investigation. So instead of just answering the question for one individual, now we are trying to handle the question for a group of persons. Well, so that is not the only question. Another example is, for example, we may be interested in trying a new drug shown to be a potent vasodilator in dogs need to be tested in well-defined clinical trials in hypertensive patients to assess its efficiency and safety in lowering blood pressure and preventing stroke, heart attack, blindness, and kidney failure. So this is another kind of problem which we can answer through this. Well, main areas of interest in this clinical are etiology, diagnosis, prognosis, treatment, prevention, analysis of the risk and benefits of diagnostic and therapeutic maneuvers. Actually. Well, instead of going into detail of each of these area, what I will do that I will talk just in terms of that example of Mr. Gupta. So I will talk about these areas answering to are relating it to the Mr. Gupta's problem actually. So for example, in etiology, the question will be what are the causes of coronary artery disease? So this will be the etiology. So based on, so this question can be handled separately actually. So based on the epidemiologic studies, it is widely acknowledged that smoking, hypertension, high blood cholesterol level, insufficient exercise, and a high stress so-called type A personality significantly increase the risk of heart attack. Well, in the terms of the diagnosis, the question asked will be how is this coronary artery disease diagnosed actually? So a variety, so this is a separate, so what I'm trying to say, all these area of interest are the separate area and the method of handling them is separate actually. A number of different technique is used for handling all the problems in all these area of interest. So question of diagnosis with reference to Mr. Gupta will be how is this CAD diagnosed? So a variety of invasive and non-invasive diagnostic tests have been developed to assess the anatomic state of the coronary arteries, the dearrangement in blood supply to the heart muscle, and the resulting tissue damages. So before such tests achieve wide application, they should be subject to appropriate epidemiologic study to ascertain their ability to discriminate accurately between individuals with and without CAD. So this, as I said, is a separate area. There are some gold standards tests available in for all the diagnosis. So when a new diagnostic test comes, so that is compared with that gold standard actually. Then comes the prognosis. So prognosis in Mr. Gupta's case will be that medical is the prediction of the future course of disease in a particular patient. The principal aims of medical prognosis are related to the management of the patient's illness, including the provision of advice to the patient and his relatives during the treatments or after the treatment, the choice of therapeutic measures and ancillary care, and the possible administration of prophylactic measures against further adverse events. So this is the prognosis. So again, as I said that problem of prognosis and separate statistical tools or methods are used for handling the prognostic problems. So question again in reference to Mr. Gupta in prognosis will be what is the likelihood that Mr. Gupta will still be alive in 5 years after getting treatment? So epidemiologic inquiry has made substantial contribution to our understanding of those clinical, demographic, psychosocial variable in CAD patients that are significantly related to future morbidity and mortality. These prognostic factors are analogous to the risk factors associated to the etiology. So some part of it is common with the etiology actually, prognosis. So, but include in addition various indicator of the extent and severity of the underlying disease in questions, which is not covered under the etiology actually. Then comes the treatment. So this factor of clinical immunology has already been mentioned about whether, so that is the question we started with actually about this treatment. So this factor has we already mentioned whether Mr. Gupta should receive surgical or medical therapy. So most question about theoretical efficacy, that is surgical versus medical, drug versus placebo, drug A versus treatment versus no treatment are best answered by means of experimental epidemiologic studies, also called clinical trials, which I will try to cover little bit at the end. Prevention. So question, how can CAD be prevented? I mean, so this is actually epidemiology tries to concentrate more on the prevention. That is what we say, that it is a better prevention than the treatment. So if a disease can be prevented from the beginning, so that will be a better alternative actually. So question is, how can CAT be prevented? So some epidemiologists distinguish here between primary prevention, preventing the disease from developing in the first place. So we have to be very careful when we talk about this prevention actually. So we call what is called the primary prevention. So preventing the disease from developing in the first place. And secondary prevention is preventing progression or complication of disease when it is already present. So most epidemiologic studies suggest that changes in smoking, eating, and exercise behavior and improved control of hypertension are responsible for the clearly perceptible decline in morbidity and mortality from this coronary artery disease actually. Then this is the analysis of benefit. This is actually from the point of the government actually. Government policies are made. So this is a separate branch now developed as health economics. So here, of course, we are talking about one individual, Mr. Gupta, so for treating him for CAD. But the question comes now, when Mr. Gupta suffered his recent heart attack, he was hospitalized in a specially staffed and equipped unit called a coronary care unit. So suppose it can be shown that CHUs result in a slightly lower rate of post-infarction mortality. मतलब क्योंकि caste काफी ज़्यादा, so we have to consider that caste factor also. So if he is getting the treatment in a government hospital or government facility, so then we have to think about the cost also. So suppose, however, that the constant noise, light, and tension of such units kept most patient from sleeping and resulted in some developing stress ulcers. So questions come now, how great a reduction in cardiac mortality would be necessary to justify this increase in non-cardiac morbidity? Question, suppose it costs 1 million rupees in this coronary care unit expenses for each 10 years of life saved by the unit, is it worth it? So since financial resources are limited, so can a greater reduction in cardiovascular mortality be realized by spending that 1 million rupees on mobile emergency rescue vehicles? So the question is now on the distribution of the money actually. So whether government should spend money on this part or you should go for this part actually. So health economics itself is now a separate branch now. So can these 1 million rupees be spent on an anti-smoking campaign, which is one of the causes of this CAD? So this is the, so of course I will not go into this, but I want to just give a brief idea about this branch also. So now health economics is weighing the potential benefit, risk, and cost of different diagnostic, therapeutic, and healthcare approaches, comprises a set of activities including disease analysis, cost benefit analysis, and cost effective analysis. So these are the areas in the health economics and through which these government policies are made actually, whether the money should go for this or money should go for this actually. So now current or future relevance of this epidemiology. So these are the some questions which are again I have posed, which can be answered through this epidemiologic studies. Does coffee consumption increase the risk of developing pancreatic cancer? Will daily aspirin administration lower the risk of myocardial infarction or sudden cardiac arrest? What are the risks and benefits of home labor and delivery? Does tight control of blood sugar improve long-term prognosis in patients with insulin-dependent diabetes? What are the diagnostic benefits of new imaging techniques such as position emission tomography and magnetic resonance imaging? These are but a small sampling of the questions whose answers will require epidemiologic data. So now comes the statistician in the picture. Here comes the role of biostatistician. So biostatistician assist with design and conduct of the study, including randomization of subjects, data collection, data analysis. They help to report the results of the study and to ensure that conclusions reached are supported by the data. So biostatistician greatest strength as a consultant are his ability to listen intently and to explain statistical design and methodology principle to physicians clearly. Because the main thing is that as I said, when I talk to these doctors, that if you start any study, you should consult the statisticians from the beginning. Because if you have not chosen the correct, correct design, or you are not using your data correctly, then statistical methods cannot be applied actually. So biostatistician's greatest strength as a consultant are his ability to listen intently and to explain statistical design and methodology principle to physicians clearly. But practicing clinician will also require considerable knowledge of epidemiology if they are to interpret and apply published research to the best advantage of their patients. So this is very important. कि खाली biostatistician ही को, so biostati, what I am trying to say, biostatistician should try to learn the language of the clinician, and clinician should try to learn the language of the statistics. So he should have some basic knowledge of the statistics. A clinician, only then benefits of any statistical analysis can be taken actually, and only then they can be applied to the real advantage of their patients actually. So this part is very, so I'm emphasizing this part. The main thing is that statistician can do very good analysis, but if this good analysis cannot be understood by physicians, then there will be no, because that analysis has to be converted into clinical language, or that requires both the biostatistician and the clinicians actually. So characteristics of the successful biostatisticians are, so a successful biostatistical consultant possesses many skills. The consultant must have a solid technical background in biostatistics, that is theoretical background, good knowledge of the subject matter area, excellent computing skills, and the ability to apply or develop necessary statistical methods innovatively in a variety of settings. A successful biostatistical consultant should be aware of his her limitations and know when to ask for assistance from a statistical or subject matter colleague, or to learn about the appropriate statistical methodology in the literature. Other important characteristics are enthusiasm in participating as a member of team of research investigator, the capability of formulating problems in statistical terms, a proclivity for problem solving, and excellent communication skills, both oral and written. This part is very, that is excellent communication skill, that how to communicate with the pupil from different areas. So now I start with the basic background material, measurement. So variables. Now, so as I said that I will be giving a definition which will not be suitable to hardcore statisticians actually. So these definitions are for persons from the other area, so they can just understand it. So I'm not giving any mathematical distribution of the variables. So attributes or events that are measured in a research study are called variables, since they vary, that is take on different values in different subjects. Then there are two kind of variables, dependent versus, again, the rigorous definition of this will be very complicated, but here I have given a definition understandable to clinicians and the other persons from other disciplines. Independent variables are those that are manipulated, whereas dependent variables are only measured or registered. So the term dependent and dependent variable apply mostly to experimental research, where some variables are manipulated, and in this sense they are independent from the initial reaction patterns, features, intention, etc. of the subject. So in some, in some study actually this distinction of dependent and independent variable not be required actually. So this distinction, when it is required, so this will be in this way. Some other variables are expected to be dependent on the manipulation or experimental conditions. So they depend on what the subjects will do in response. So actually, sometimes that's why these dependent variables also are called the response variables actually. So as a very simple example, say if an experiment males are compared with females regarding their white cell count, so gender could be called the independent variable, and the white cell count will be the dependent variable, because this white cell count will depend upon the sex, whether it is female or male. Well, then there are types of variables. Continuous, again, this is not the rigorous definition of continuous variable from a statistical point of view. Continuous variables can, in theory, assume an infinite number of values and are expressed in integer fractions or decimals asystolic or diastolic breath pressure, serum sodium concentration, number of children in a family, and many subjective states such as pain, disability, or mood are all examples of continuous variables actually. Categorical variables are those in which the entirety measure is placed into one of the two or more categories actually. That is, they can categorize. So examples of dichotomous categorical variables include, say, vital states, dead or alive, yes versus no response to a question, and sex, say male or female. Then there are four kind of measurement scales. So this is in order of the preference actually. Nominal is the least significant, important. So nominal variables allows for only qualitative qualification. That is, they can be measured only in terms of whether the individual items belong to some distinctively different categories, but we cannot quantify or even rank order those categories. For example, all we can say is that the two individuals are different in terms of variable A. For they are of different race, so they can put one of the categories of these races. But we cannot say which one has one more of the quality represented by this variable. Okay, whether one race is better than the other, we cannot quantify or we cannot rank that. We can just put them in one of those categories. So typical examples of nominal variables are gender, race, color, city, etc. Then the next preferential measurement scale is the ordinal. So in this ordinals allows to rank us. We can rank the order the items we measure in terms of which has less or which has more of the quality represented by the variable. But still they do not allow us to say how much more. That is, we cannot quantify. Only we can rank them, that it is rank 1, he is better than this, or he is best or that, but we cannot quantify how much better or how much worse actually. So a typical example and ordinal variable is the socio-economic status of the family. For example, we know that upper middle is higher than middle, but we cannot say that it is, for example, that it is 18% higher or 25% higher. Only we can order them. So then the next significant one is the interval scale. So interval variables allow us not only rank order the items that are measured, but also to quantify. So now we can quantify them and compare the sizes of the difference between them. For example, temperature as measured in degrees Fahrenheit or Celsius constitute an interval scale. We can say that a temperature of 14 degrees is higher than a temperature of 30 degrees, and that an increase from 20 to 40 degrees is twice as much as an increase from 30 to 40 degrees. But here again, you have to keep in mind that here we cannot compare it. When we say that the temperature of 40 degrees is higher than a temperature of 30 degrees, and that an increase from 20 to 40 degrees is twice as much as increase from 30 to 40 degrees. But here we cannot say that 40-degree temperature is twice as hot as 20 degree actually. So you have to keep in mind actually. Here only we can quantify the difference, but we cannot quantify the multiplicity actually. So now that has been taken care into the ratio scale. So the ratio scale is the most precise one. So ratio scales are very similar to interval variable. In addition to all the properties of interval variable, they feature an identifiable absolute 0 point. Thus, they allow us statements such as x is 2 times more than y, which we cannot do in an interval scale. So interval scale is not has a different absolute 0 actually. So now again, from the mathematical point of view, so we can do addition and subtraction for interval scale, but we cannot do multiplication and division for the interval scale. But all the four these addition, subtraction, multiplication, and subtraction can be applied to the measurement scale. Well, typical examples of ratio scales are measure of time or space. For example, as the Kelvin temperature scale is a ratio scale. So not only here we can say that a temperature of 200 degrees higher than one of 100 degrees, we can correctly state that it is twice as high, which we cannot have said in the case of the interval scale if we are using the Fahrenheit or the Celsius. So interval scale do not have the ratio property. So most statistical data and research procedure do not distinguish between the, but from the analysis point of view, actually we do not make distinction because jada whatever the statistical techniques are, they are applicable to interval scale as well as for the ratio scales actually, data analysis point of view. Now sources of variation in measurement. So when a measurement is performed on a single subject, there are two possibilities of variation. Two sources of variations can affect the result. So this is important. So one can be the biological variation and the second is the measurement error. Well, in the biological variation reflects the actually dynamic nature of most biological entities and lets the difference between individuals of different age, sex, race, or disease states. A subject's biological attributes can vary over time in response to a variety of physiological functions and other factors. To the degree that such changes are regular and predictable, intra-individual temporal variation can be reduced by the investigator. That is, biological variation can be handled by the investigator. For example, in measuring a variable such as plasma cortisol concentration, which is known to have a regular diurnal cycle, variability is reduced by drawing the blood sample at a specified time of day. So this biological variation in this variable we can handle if that blood sample is taken at a specified time of the day. But now let us come to the measurement error. Every measurement error is subject to some degree of measurement. So there are two different kind of measurement error. One is random error, which is what statistically handle actually, and second is the bias or systematic error. So as you know, random error usually cannot be controlled by the investigator. So when a single measurement is obtained, there is simply no way of knowing if the difference error between the measured value and the true biological value is due to chance or bias. So the distinction can be made only when the measurement is repeated. So if the average value of a large number of repeated measurement is same as the true biological value, then the reason for the disparate single measurement is random error. But if the variable average value is also erroneous, then the explanation is bias. So this is the difference between the bias and the random error. Both are trying to handle through the repeated measurements, but the distinction comes when we take the average values actually. So I'm trying to give this example of this chance and biasment in measurement error. So in this figure, you are seeing the data. So there are 8 repeated observations in all the 4 cases. In the first cases, there is little chance of random error, but this true value is away from the this value of average value of the measurement is away from the true measurement. So this is biased and little chance of variable. In the second case B, here the average value is close to the true value, but there is too much variability in the data. So here this is unbiased, but there is a lot of variability. In the third case, there is a lot of variability as well as it is away from the. So here we have bias as well as lot of random error, and this is the best situation where we have a least bias and we have unbiased. There is no bias and there is little chance of the. So here each measurement is repeated 8 times. Measurement A is biased but subject to little random error. B is unbiased but subject to considerable chance variation. C is both biased and highly variable. And measurement D has the smallest propensity of error. It is both unbiased and relatively invariable. So this fourth position is the best situation actually as far as this measurement error are concerned. So sources, what are the sources of measurement error? Measurement error can arise from either the method that is measuring the instrument or the observer. And when measurements are repeated, we can distinguish between the variability that occurs when the same method or observer is repeat the measurement. So this is intra-method or intra-observer variability, and the one which occurs between the two or more methods or observers. So that is between the, so this is inter-method and inter-observer variability. Well, repeated measurements are used in broader sense. When I am saying repeated, so here you don't have to consider that the repeated measurements are taken on the same subject. Actually, the measurement can be done over different subjects, that is repeated over subjects, or measurement can be repeated on same subjects also. Well, in terms of epidemiologic study, measurement instrument in epidemiologic studies need not be a mechanical device like some instrument. Death certificate, questionnaires, and psychological tests are also called as measurement instruments. Actually, that is, they are the instrument for collecting the data. Well, then there is one more concept of regression towards the mean, which is not familiar, very much familiar in the statistical world, but it is important from the clinician point of view. So when repeated measurements are obtained, biological variation and measurement error interact to produce a phenomenon known as regression towards the mean. That is, we are trying to minimize both kind of variation, measurement error as well as biological variation. So for many biological attributes, most individual in a group will have the true values, which is close to the average value. But some individuals might have some extreme values, extremely high or low value obtained in an individual from that group is more likely to be an error than an intermediate value actually. So how to handle this high or low value actually? So when the measurement is repeated, the tendency towards a less extreme repeat value, that is a regression towards the mean, is greater than the tendency for intermediate value to become more extreme actually. So in practical terms, this means that if we select a group of subjects because they appear abnormal on some tests, that is their score differs from the mean, they will seem to improve when they are retested. So this is often done in the hypertension trials, in which the person has to have 3 consecutive abnormal readings before being called hypertensive. So here we take more than one reading, and then we try to either take the average of that, or if there are some extreme values, then we take the median value actually. Now, properties of measurement. What are the should be properties of a good measurement instrument actually? So first is the validity, reproducibility, which is also known as the reliability, and the detail. Validity of a measurement is the extent to which it corresponds to the true biological value or some accepted gold standard. Validity depends on minimizing measurement error caused by bias. As you said, we have talked about 2 kinds of error. So validity depends on minimizing measurement error caused by bias. A valid instrument thus requires both a valid method, that is instrument for measurement, and a valid observer. Validity, unfortunately, no gold standard for many variables of the interest or new areas, gold standard does not exist actually. So it is impossible to know with certainty how much pain or anxiety a patient is experiencing, or the extent of the cellular dysplasia in a cervical smear. The validity of such measures thus cannot be assessed. Instead, a variety of proxy indexes of validity are used. So there are different kind of validity. Face validity is the extent to which the measure appears apposite or appropriate to the entity measured. Content validity pertains to the appositeness of the individual items or components of the measurement. For example, the individual questions in a questionnaire scale designed to measure depression. Concurrent criteria validity is the degree to which the measurement correlates with other accepted measures criteria of the entity. obtained at the same time. For example, the presence of tears in patients scoring high on our depression scale. Predictive criteria validity is the extent to which the measurement predicts some accepted criteria of the entity that occurs in the future. If, for example, only those patients who appear severely depressed on our scale subsequently commit suicide, the depression scale measurement can be said to be a valid predictor of suicide. Construct validity is the extent to which the underlying entity itself, that is theoretical construct, is valid. The validity of depression as a construct is well accepted. Now we come to the second property, reproducibility. The reproducibility of a measurement is the degree to which the same results are obtained when the measurement is repeated. It may reflect either temporal variation in the underlying biological attribute or random measurement error due to method and our observers. The most used term for this measurement property is reliability, but the term is misleading since it seems unwise to rely on a measurement that may be invalid merely because it is reproducible. Well, we should not contest on this. Statisticians prefer the word precision, which unfortunately can be confined in its normal English usage with measurement detail actually. Again, let me go to example. So I am coming back to that example I gave earlier for that bias and random chance. So here again, I am come back to that example. So in this example, if you see, just see to measurement A. So here measurement A is highly reproducible, but it is biased and therefore it is invalid. So example A is of a reproducible instrument, but it is invalid. Then, so it may be biased systematically upward or downward. For example, an incorrectly calibrated serum glucose auto-analyzes that reproducibility gives values above the true value concentration. So then we have to see the direction of the biasness also actually. So it may be consistently biased towards a given value. For example, if you take an example of broken watch, will reproducibility give the time? If you keep watching a broken watch, so you will be getting the measurements. So you will be, those will be reproducible, but they will be only twice a day because you will get time correct to be only for 2 times a day for a broken watch. So measurement may be purely reproducible but unbiased, which is the case of the measurement B actually. So measurement B is unbiased, but it is purely reproducible but is unbiased measurement. So when such a measurement is taken with several, the average value of the replicas may have a good validity. So the situation B is of a good validity, but it is purely reproducible. So this is common practice in epidemiologic studies for variables such as height and blood pressure, which are subject to considerable intra and inter-observer error actually. Now, third property is the detail. Now, the detail is that how detailed a measurement should be taken. The detail of a measurement is equivalent to the amount of information provided. For continuous variables, this usually means the number of significant of decimal, whether we should use decimal 1 places, 2 places, or whole number. For category variable, details refer to only the number of categories contained in the scale. But ideally, a measurement should be sufficiently but not excessively detailed. This is very important. So details should be sufficient to distinguish individuals or groups with true differences in the entirety of interest, but it should not be excessive in the sense that measured differences are of no biological importance. Furthermore, the detail of measurement should not exceed its validity and reproducibility. As an example, say if we are measuring serum glossum concentration, so this is usually measured nearest to the mg per dl, measurement to the nearest 100 mg per dl, but it will be insufficient in distinguishing normal subjects from those with hyperglycemia on the other hand or diabetes on the other. So even the measurement to the nearest 10 mg per dl might be insufficient to document improvement or deterioration in diabetic control after changes in insulin doses. But on the other hand, if we try to take the measurement current to 0.1, so this will be useless actually, because we don't need that accuracy. So this detail has to be decided before we take the data. So now with this background that how we should collect the data, how our data should be, what should be the property of the data. Now I'm going to talk little about the analysis part actually. So the first thing comes is the rates, or which is called the measure of disease frequency. So rates, you are familiar. So rate is nothing but it is a proportion and describe the part that possesses a particular attribute compared to the whole. So for example, the immunization rate is defined as the proportion of newborn babies that receive their immunization during their first year. For the community of 2000 newborn babies, if 1800 have their first immunization during their first year, the rate will be 90%. So now there are two different kind of rates, prevalence. So we have to make a distinction between prevalence and incidence rate. The prevalence rate of an attribute or event in any group is the proportion of individuals in the group having that attribute or event at one point in the time. This point is important, at one point in time. So number of individuals, so numerator is the number of individuals with attribute or event at a given point in time, and the denominator is total number of individuals in the group. Prevalence, on the other hand, incidence rate is the proportion of any fixed group developing an attribute or event within a specified time period. So this is the main difference. Prevalence is taken at a specific point of time, where the incidence rate is collected for event within a specified time period. So numerator here consists of those individuals. So here we have to define this numerator very carefully actually. The numerator consists of those individuals who were free of characteristics at the beginning of the period and who developed it during the period. And the denominator is the total number of individuals originally free of the characteristics who could have developed it during the period. So you have to take the whole group during that period. Whereas in the prevalence, we have to take only at a specific point of time. So incidence rate is the number of individuals who develop attribute or event during the specified time period. And the denominator is the total number of individuals in group who could have developed attribute or event during the specified time period. Incidence is thus a measure of frequency over time. It refers to change in status over a specified period. For example, monthly incidence or annual incidence. So let me, to make this point clear, I'm taking two statements. So during October 1981, a team of nurses examined each adult on an Indian reservation in New York State to determine the proportion of adults with positive skin test to PPD. And in the statement, a dentist in a hospital practice counted the number of patients presenting at her office with newly developed hyperkeratotic lesions on the oral mucosa during the month of November 1981. The dentist also counted the total number of patients in her practice during the same month. So now the question is, what is the difference between the statement A and B in reference to this prevalence and incidence rate actually? So the answer is that, so question is, so answer is in situation A, question you have to pose is what rate were the nurses attempting to learn in statement A and what rate did the dentist tabulate in statement B? So in situation A, the nurses were attempting to determine the prevalence of positive skin on the reservation because they were measuring on a specific time. And in situation B, the dentist was trying to determine the incidence of hyperkeratosis for the population of patients served by the hospital practice during the whole month. So this will go in, so statement B will go into the incidence and statement A will go into the prevalence section. So these are some standard annual incidence rates which are used in demography actually. crude birth rate. The main thing is that here the denominator, the number is not expressed as a percentage. That is, it is these rates are not expressed as percentage, that is per 100. These may here they are expressed in different numbers. For example, crude birth rate is expressed in per 1000. General fertility rate is expressed per 1000. Crude mortality rate is expressed in per 1000. Maternal mortality rate is expressed in per 1 lakh. Paternal mortality rate is per 1000. So most of them are expressed in terms of 1000, but in which the number is numerator is small, then they are expressed in terms of greater number like 1 lakh or so thousand. And main thing is the denominator, you see, because most of them are the incidence rate, so you have to be careful. So denominator is mostly taken to be the mid-year population actually. In how to count the population throughout the whole year. So we have decided at one point of taking the denominator as the mid-year population. So what are the uses of these incidence prevalence rate? The incidence rate of an attribute or event is the frequency measure of choice when interest focuses on the cause of that attribute or event, because causal factors operate prior to the development of the effect they cause. Causal reasoning is enhanced by knowing that individuals are free of a characteristic before being exposed to the causal factor under suspicion. Furthermore, rapid recovery or death from the characteristics of interest will prevent its detection if only prevalence is known. So in order to show detection of all new cases, however, calculation of incidence requires measurement of the characteristics in all individuals within a group at the beginning of the follow-up and systematic assessment of its occurrence until the end of follow-up. Prevalence, on the other hand, is much easier to calculate since it requires only one measurement of individuals in a group at a single point in no time. No follow-up or repeat measurements are required. Furthermore, prevalence is quite useful for describing the extent or burden of an attribute in each community or clinic. Prevalence is therefore of great importance from a public health perspective, since health care services are often distributed according to need, that is existing health and disease status. For example, conditions like arthritis and heart diseases usually consume far greater resources than do more commonly occurring but shorter lived diseases like the common cold or viral gastronitis. Finally, although not generally appropriate for making causal inference, prevalence rates can occasionally be useful in suggesting hypotheses, that is in generating the hypothesis when incidence rates are unavailable. So comparison of the prevalence of, for example, cardiovascular disease among different types of societies might give rise to etiological clues based on the differences in diet, physical activities, or other characteristics of those societies. So now comes so here when I was talking, so here I was talking about the rate just for one group. But when we come to the more than one group, that is when we have more than two groups or two groups, then comes the question of comparison also, comparison of those rates among the groups. So here we have to, so when comparisons are made between the rates into a more groups for the purpose of generating or testing etiological hypothesis, so important difference in death rates in two separate communities, for example, lead to research into possible genetic, dietary, environmental, or psychosocial factors that might explain the difference. As in all comparison, however, we must ensure that we are comparing like with like and that the presence of some extraordinary factor is not biasing the comparison. This part is very important. That is comparison is not just straightforward actually. You just not compare the rates in two different groups without giving any other thoughts actually, without taking any other things into considerations actually. So for this, so a comparison between groups on a given attribute can be biased if some extraneous factor that can affect that attribute independently of group membership is unequally distributed between the groups. This kind of bias is called the confounding bias. So this is the concept very important in the epidemiology study of this confounding factor. So this factor will be responsible for creating the bias or this concept of confounding is fundamental in epidemiology, and we shall see how it may bias a comparison between rates and how so-called crude rates may be stratified and adjusted to reduce or eliminate such bias. So now we have introduced the term of the crude rate. So if we make comparison without giving any thinking about these confounding variables, so that will be the crude rate. But that comparison is not fair, as will be clear from this example. So this is the comparison of annual death rate in two United States communities. There are two communities, Millville and the Sunnyvale. So this is the age group 0 to 14, 15 to 29, 30 to 44, 49, 60. So these are the populations in these age groups in the Millville. These are the populations in the Sunnyvale. These are the deaths in different age group, and these are the death rates. So, and so you can see the overall death rate comes out to be 11 per 1,000 in Millville, and in Sunville it comes out to be 23.8. So it looks like the death rate is twice more than in Millville. Because so this is the comparison of the crude rate. So here we are not thinking anything else. We are just comparing the death rates in the overall death rate based on this actually. But so here the above table compares the annual death rate in two small communities. The overall crude rate in the two communities are shown in the last row, as you have seen. So here that is two more. But if you see a closer examination of the individual rows corresponding to the different age group or strata, this reveals the opposite actually. So here if we come back, so now if you see stratum wise, actually the problem is here actually in the Millville, in the age group 0 to 45, there are 74% people. And whereas in this Millville, in this age group, there are only 28%. And the thing is opposite in this group 45 to 75. So here there are more people in Sunville than in this. So this is actually, this is creating the problem actually. So this direct comparison of the crude rate will be not fair actually. So here, so if you compare the death rate stratum wise actually, so you will see the picture is opposite actually. For example, here the death rate in Millville is 1,000 as compared to in the age group, that is it is 4 times. Similarly, in 15 to 29, the death rate is 4 times the death rate. Similarly, the death rate in the group this is more than this. Death rate in this is this. So, but although the stratum wise the death rate is more in Millville, but overall the death rate comes out to be more in Sunnyville. So this is the problem actually. So now the discrepancy is caused by age distribution that is quite different in two communities. With Sunnyvale is having a much older structure of 74% is under 45 compared with only 28%. So age is here a confounding factor. It is unequally distributed between the two groups and is independently related to the attribute of interest. So just direct crude comparison of crude rate will make no sense actually. So now the question comes how we should adjust these rates actually. So stratification of rate is accomplished by comparing the stratum specific rather than overall rate, and is one method of eliminating bias due to confounding. We might, however, prefer some overall measures that combines the data from all strata without introducing the bias. This is especially important when the stratum specific rates reveal a mixed picture with some rates higher in one group and other rates higher in the second, which is the case here in this example actually. So there are two methods of adjustment: direct standardization and the indirect standardization. In direct standardization, the observed stratum specific rates in the two groups are applied to a third standard group or population with known stratum structure. So because as we saw that age-wise structure was quite different in the two communities, So here, instead of taking the age-wise structure of those two communities, we will take the age-wise structure of a standard population, and that will be common to both the communities actually. So now you can see that we have taken this standard population. So this is the age structure of this standard population. And now the original age structure of Millville and Sunnyvale has been taken out. We have, so now this age structure will be common to both Millville and Sunnyvale. So now the death rates will be obtained on the basis of this standard population. So this is the standard population age structure. These were the deaths in Millville. These were the deaths in Sunnyvale. So now we calculate the expected rate based on these population actually, this age structure. So 2 will be this, 10 will be this. So 1000 will convert into 2 expected date. Similarly, here in deaths were 5, so this will convert to 2.5 per 1000. Expected dates will be 1.25 and so on. So these are the expected dates and these will be the total. So now you can say that the expected dates are 235 in Millville and expected dates are 201.5 in this group. So we, in conformity with the overall standardized rate, reveal a higher annual death rate. So now if you will calculate the death rate, so death rate in Sunnyvale comes out to be 16.8, whereas the death rate in Millville comes out to be 19.6. So the picture completely overturns actually. So now you can see that the death rate in Millville is actually more than the overall death rate in the Sunnyvale. So here, the after taking this confounding factor into account, the picture, we get the correct picture. Well, now the question is, what is this standard population? Well, the choice of standard population is arbitrary. The standard population should reflect the age distribution of the population to which one wishes to generalize the results. In this example, the standardized death rate tells us the death we would expect if the standard population of 12,000 lived in Millville or Sunnyvale. A better standard might be the entire US population maybe. When no standard is available, the groups we compared are often combined into a single standard. Maybe we can combine the, agar standard population is not available, what we could have done is, we could have combined the population of Millville and Sunnyvale together and taken that as the standard population. Well, this is a second method of standardization. Here, this method is used in one or more of the following circumstances: when small numbers led to potentially unstable stratum specific rates, when the stratum structure of the standard population is unknown, when the overall death rate and stratum extractions are known for the compared group, but their stratum specific rates are unknown. Indirect standardization always requires knowledge of the stratum specific rates for the standard population. So this is the difference between the direct standardization and the indirect standardization, this last one. In direct standardization, we were using the standard population. So that standard population was stratified into different age groups, and we use that as a common one for comparing the deaths rate in both the communities. But in indirect standardization requires knowledge of the stratum specific rates for the standard population. So as this is clear in this example, so these are the age groups and these are the death rates in the standard population. So these death rates will be used. So this will be common. So here this age-wise death rates will be common for Millville and Sunnyvale, and the population structure will be used the original one, which was, so this is the original population structure for Millville. This is the original population structure for the Sunnyvale, and we are using these common age-specific death rates. So this, on the basis of this, we have found these expected days. So these are the observed days. Similarly, these are the expected days for Sunnyvale and these are the observed days. So the total observed deaths are this, and this is the total population. And similarly here, so these are the observed deaths for Sunville, and these are the observed deaths for Millville. So now these are the calculations now. So we first calculate the standardized mortality ratio, which is the observed death divided by the expected death. So observed death divided by the expected death, observed death divided by the expected death. So this is the SMR for Millville. This is the SMR for Sunville, and standardized death rates are then this standard mortality rate into death rates in the standard populations. So these were the death rates, common death rate in the standard population. So this is used here. So these are the different SMR. So now this comes out to be standardized rates for Millville, and this comes out. But anyway, the result almost is not parallel. But here also the overall death rate for Millville is more than the overall death rate for the Sunnyvale, which we also found in the direct standardized method. But it is the result is different from when we are comparing the crude rates actually. So now the question comes, what should be the, so this confounding variable is very important, as you can see there. So the question comes, since here age, so here it is obvious, since age affects many of the attributes, for example, so events are, so in lot of example, age is the confounding factor, but there will be a lot of more confounding factors actually. Depending on the attributes are even measured and the characteristics of the groups compared, other variables may have an equal or greater potential. So a comparison of death rates from lung cancer in this versus coal miners should standardize by cigarette smoking status unless there is a good reason to believe that the two groups of miners have similar smoking habits. So the choice of variables by which to standardize thus depends on existing biological and clinical knowledge. So these confounding variables have to be decided between the clinician and the statistician actually. So this will vary from one study to the another study. For example, the same variable may not be a confounding variable. It can be a confounding variable for one study, but it may not be a confounding variable for another study. Now these are some different study designs. So the research designs can be broadly classified into 4 categories from the point of view of in different disciplines. Experimental designs, we have factorial design, which are mostly used in psychology. Randomized control design are the one which are the best for the clinician, clinical point of view. These are the best ones. Then there are some intact group design, cohort studies, which is used in occupational health, case control studies, which is used in occupational health. I mean, I'm just giving example. It is not that these study can be used only in these kind of things. Well, they can be, but they are most common in these fields. This is what I have given in the bracket, that these studies are most common in it, but they can be used in other areas also actually. Case control studies, non-equivalent control group, time series are common in economics education. Then surveys are cross-sectional. These are very common. Longitudinal panel psychology. Then we have qualitative design, ethnography, key informants, in-depth interviews, focus group, life story. So here we have the data, not quantitative data. We will be having the statements and all those. So this is a separate field actually. The analysis of qualitative, this is a quite different field. Those quantitative analysis methods are not applicable here in qualitative design sector. So here we shall focus only on 4 because time is very less. I have to just give a brief review actually. So I have considered these 4 studies from a medical or clinical point of view. So these are the studies which are mostly used in clinical studies actually. Cohort studies, which is also known as observational prospective study. Randomized control trial, which is the experimental prospective studies. Case control studies, retrospective study, this is going backward. Cross-sectional studies is also known as observational or descriptive or analytic study. In experimental study, researchers have control or intervention. In observational study, researchers do not have control over intervention. In prospective study, that is going in the forward direction, data are gathered after the start of the study. In retrospective study, data are recorded backward. And case control design and cohort studies are also known as quasi-experimental design. So let us first come to the cohort studies. An analytic cohort study is a study in which subjects are followed in a forward direction from exposure to outcome. We go in this direction. So study subjects are free of the outcome at the time exposure begins. Well, exposure to the putative causal agent or treatment is not under the researcher's control. Or in other words, it is either not feasible or not ethical to randomly assign patient to be exposed or not to be exposed to the putative causal agent. Investigator must find an alternative to an randomized control trial. Subjects are divided into exposed or treated and unexposed or untreated groups based on past history. The unexposed group is often called control group or control cohort. What will be the baseline state? The baseline state of a cohort consists of the characteristics of its members before exposure. This is also known as the baseline characteristics. It includes, for example, geographic, socioeconomic, socio-demographic, for example, age, sex, race, marital status, and clinical attributes. The main importance of an adequate description of the baseline state is the control for, again, this confounding bias. Very simple example of this cohort study is we have a group of women which use video terminal displays during their pregnancy, and a second group who did not use them, and both groups are followed to determine the rates of miscarriages, stillbirths, and congenital abnormalities. So this is the prospective cohort study. We have divided the subjects into two groups, but they will be followed prospectively. Another example, investigator assess parental outcome among children of men exposed to lead and organic solvents in the printing industry using a cohort of all males who had been members of Printers Union in Oslo, Norway, and on the basis of job classification, they categorized father as to their exposure to lead and solvent. In this study, exposures were associated with an 8-fold increase in preterm births, but no significant impact on birth defects. Cohort studies may also be performed when harmful outcomes are infrequent. Clinically apparent under gastrointestinal hemorrhage in non-steroidal anti-inflammatory drug users occurs approximately 1.5 times per this person years of exposure in comparison with this in those not taking. So here we can use cohort studies in one group consisting of this and the other group consisting of, because here if we would have used randomized control trial, then it comes out that the number of subjects we have to take may be in millions actually, which is little difficult actually. So what kind of statistical analysis is used for this cohort study? Because subjects in a cohort study select themselves, are selected by a physician for exposure to the therapeutic harmful agent, there is no reason they should be like non-exposed person with respect to other important determinants of outcome. It therefore becomes crucial for investigators to document the characteristics of the exposed and non-exposed subjects and either demonstrate their comparability or use statistical technique to adjust for the differences. In the association between, and that is in that example, and NS and the increased risk of upper gastrointestinal bleeding, age is associated with both exposure to NS group and with gastrointestinal bleeding and is therefore called a possible confounding variable. In other words, since patient taking NS will be older, it may be difficult to tell if their increased risk of bleeding is because of their age or because of their NS exposure. So when such a confounding variable is unequally distributed in the exposed and non-exposed population, investigators use statistical techniques that correct or adjust for the imbalances. So here what we are trying to say is that here comes the role of statistical analysis. Actually, this confound, of course, first question is to find the right confounding variable. But once the confounding variables are found, whether we can take care of this confounding variable in the statistical analysis? And the answer is yes. Of course, there are a lot of techniques which of course we cannot go into detail. Then we come to the case control study. In case control study, we start with the outcome and ask for found out about prior exposure, because here the direction is backward. In the previous case, the direction was the forward from exposure to outcome, but here we start with the outcome and try to find out the exposure. So directionality is the backward and the reasonably is inductive from effect to cause. Some synonyms for this study are Cohort, case reference study. The generally accepted term case study derives from the usual dichotomous categorization of the outcome as present or absent. In sample selection in the case control study, prior exposure is assessed after the study subjects have been assembled. Thus, the study sample may be selected from the target population by either outcome status or other criteria. Regardless of which sample selection method is used, study subjects are usually classified according to their outcome status. In most case control studies, outcome is dichotomically assessed as either present or absent, and subjects are classified as cases or controls respectively. Selection of controls. As with cases, controls should be selected according to predetermined criteria to ensure the absence of the outcome. They should be representative of controls in the target population. Although it might appear that normal healthy subjects would constitute the best control group, it may be better to choose subjects with similar reference, surveillance, and other factors capable of distorting the study sample. One approach that is sometimes taken is to have a healthy community control group as well as another control group from a similar source as the case group, which can be hospital based. And the most common measure used in is the odd ratio. So just I want to introduce this. So the outcome of interest is the ratio here for case control study, or the ratio of odds in favor of exposure among the cases and the odds in favor of exposure among the controls. So how to interpret this odd ratio? A value of odd ratio greater than 1 indicate that exposure is associated with an increased risk of developing the outcome. The higher the value of odd ratio, the greater the risk. Conversely, a value of the odd ratio less than 1 indicate that exposure is associated with a reduced risk. That is, it protects against developing the outcome. The closer the value of the odd ratio is to 0, the greater the protection. Example, a study of malignant melanoma was conducted through a network of hospitals, pathologists, etc. They attempted to identify all newly diagnosed cases of the disease aged between 20 and 69 in a defined area. A comparison or control group without the disease was randomly selected from municipal rolls, which list all adults in that town. For each case, the control was someone from the same town, of the same sex, and of roughly the same age. So here we try to, when select the control, we can match as many attributes as possible. So that will be the best control group actually. Interview used a questionnaire to learn about subjects' previous exposure to sunlight, other ultraviolet radiation, occupational histories, and other factors. Comparison between the cases and controls were made for these variables to estimate odd ratios of the association between the possible etiological factors and melanoma. So a study is conducted to investigate the effect of oral contraceptive use on the likelihood of heart attack. So the 58 married women under 45 years of age treated for myocardial infarction in 2 hospitals were taken. Each case was matched with 3 control patients in the same hospital who were not being treated for. All subjects were taken, then asked whether they. So here the point which here I want to make is in the case control study, there is possibility that for each case we can have more than 1 control. We can have more than, for example, in this study we are taking 3 controls. So we would normally regard MI as a response variable and oral contraceptive as an explanatory variable here. So in this study, the marginal distribution of MI is fixed by the sampling design, and the outcome measure for each subject is whether she ever used oral contraceptive. So this is the case control we are looking in the past here actually. In the cross-sectional study, the exposure and outcomes are determined at the same time. both exposure and outcome prior to the selection of the study subject. The thinking is, so this is mostly used in the surveys actually. So I don't want to, so here the sample selection is by exposure, outcome or other criteria. Random sampling, other form of representative sample selection is often used in some study. Cross studies may profit by basing subject selection on either exposure. So when exposure is rare, statistical efficiency is enhanced when selection is by exposure. Conversely, selection by outcome is preferable when the outcome is rare. Cross-sectional studies usually measure prevalent outcomes. So mostly these are used in the prevalence studies where we are interested in just finding the prevalence rate. So for example, a cross-section survey is performed to estimate the prevalence and correlation of psychiatric disorders in Uttar Pradesh children. A stratified random sample of household in the province listed is taken for doing this survey. Household agreeing to participate were given the survey diagnostic instrument, a questionnaire to be completed by a parent. The results were used to identify various disorders and relate them to other information collected. Analysis depends on the method of sample selection. I don't want to. Analysis of results is when sample selection is by outcome analysis like that used for case control study. I mean the analysis for different kind of studies are not different. Some analysis are specific to the study, but some analysis is common to all the studies. So for example, here also outcomes can be measured in terms of the odd ratio actually. Well, clinical trials is the most prestigious study, experimental ECG, and the finding of these clinical trials is supposed to be most authentic actually. So here the clinical trial is often referred to as a treatment. Another name for the design is experimental cohort study. The previous one was observational cohort study now. So these are the, here we have a study sample and they are randomly allocated between the two treatments, treatment A and treatment B, and then we see the outcome between these two treatments. So because of their cohort directionality, clinical trials include a period of follow-up in their design. So there is this concept of follow-up. The follow-up must be sufficiently long to include the latent period of the study treatment. Then we have the blinding. Blinding of study subject is necessary to protect against contamination. That is, the subject should not know which kind of treatment they are getting. Otherwise, the results will get biased. The placebo effect is the non-specific effect that any treatment can have on the outcome. The main reason for providing look alike, feel like, so this making a placebo is very important. So the drug में placebo होता है वो इस तरह से it is makes so that it looks like the original treatment drug actually. Then we have two kind of double blinding also. So if the clinician is also blinded, I mean there are studies where clinician is also bounded and subjects are also bounded. So then we have this double blinding. For example, a multi-center randomized control trial of surgery versus medical treatment for cerebrovascular stroke was carried out in Canada. Patients who met eligibility criteria and the centers were asked to participate in the study. So consent is taken before the study is taken. There is a consent form which is given to the subjects and they have to fill that form actually. Subjects were monitored to determine if and when this cerebrovascular event or death occurred. Comparisons were made between the two groups to determine if the either treatment showed a lower rate of events or deaths. So I think this is what I can do in this time. So I think I should stop now.
Thank you, sir.
I
Thank you, sir.
am,
Thank you, Professor J.J. Agarwal, sir.
Rajesh sir, question मिला? Question है एक मैं पूछ लूं?
yeah.
Sir, there is one question from Sambhumi Mishra, participants of this FDP. So, sir, could you please explain the difference between a confounder and a effect modifier?
Yeah. I have not talked about effect modifier actually.
Okay.
You know, that is a good question. But let me answer. Confounder is a predictor. When we talk about effect modifier, that is connected to the interaction. You see, So
Right.
the point is this affect modifier is, so when we have more than one confounder, because as I said, I have tried to give it, I mean, this lecture I covered actually in one whole semester, which I have tried to give it in just one talk, you actually refresher course, because I wanted to introduce this field actually, my idea. But there are a lot of questions. So let me just, I mean, the difference between confounder and affect modifier is, affect modifier is when we have more than one confounder. So I mean, there can be interaction now. You see that in, matlab, for example, in male, one thing can go in one direction, and in female can go in another line. So there is the interaction. So that is the effect modifier actually.
Yes. So rest peoples are saying very informative session, and you have covered it almost all the aspects of topics. So
Yeah,
formally,
but I will be happy when these people will go through this and try to understand. And I mean, because I encourage people, because although I have given my talk just today, but I want to create an audience who should be communicative, who should communicate with me. And if they have any questions, and then they can interact me. So if somebody is interested, I do not want to give an advertisement, but only I will be interested in those people who will be really interested. So if they want to communicate with me, you can give them my email. So,
yeah, sure, sir, definitely.
but not to everyone, because I don't want
No,
to
no,
make
no.
it general thing.
Who is interested here?
Those who
Only
are
those
interested.
interested, because,
Sir,
because my time is
people's
also valuable.
mostly peoples are saying very effectiveness of the session. Please continue.
Yeah,
So
I can continue for hours, but I mean, I think I just try to cover with should now have a starting point if the people want to start.
so we will definitely invite you again, sir, for the
Yeah,
next lecture. Next lecture, we will invite you, sir, for the same. So formally, for vote of thanks, I will invite Dr. Brajesh. Please say thanks to sir.
Uh, really, I, Dr. Brijesh Kumar, on behalf of the Department of Statistics, I really thanks to the Professor G.J. Agarwal sir. Professor G.J. Agarwal sir accept our invitation in a very short span, and after they accepting our lecture, our invitation, and we schedule the lecture of sir today, and as the participants are saying that it is really a very wonderful and very informative session, and I also really very interested in the listening the lecture, such as sir define the statistics term in different manners, like the random variables, independent and dependent variables,
That's what I
and
said.
continuous
No,
random variable.
hardcore statistician will be will be abusing me. That
No,
statistician.
Sir.
no, sir, no, sir. Really, sir, we are very grateful to listen you how you explain these
I mean,
terms. Which
on one hand, I teach major theoretic definition of random variable, and this is
yes,
the
sir,
other aspect.
yes,
So
sir. Really, that was very interesting.
Mostly
And
people are saying that's a very informative lecture and
yeah,
useful sessions for us,
yeah,
because we are touching the ground of statistics.
no, the main
and
thing which I realize after coming to this key, I mean, how to teach statistician to the person from other field. I mean, they do not. I mean, if you will try to talk to them in mathematical terms, they will run away from you actually.
Right, right.
No, I had
yes,
problem. You see, it was not that easy for myself to mold in this, because as I said, my own PhD was in mathematical statistics. As you know, in I mean,
yes, sir.
Lucknow University also we give the degree in mathematical statistics.
Mathematical statistics.
Yes, yes,
So when I went to McMaster, this was just a different life for me actually. When I started talking to those doctors, so I thought these doctors are really knowing statistics than myself actually. If they are, how they are using statistics, for example, this concept of p-value, we never teach p-value, and p-value is so important in that. Then I mean, I never heard of this p-value, things like that. We were just
sir.
knowing the type 1 error, type 2 error, probability of type
Yes,
1
sir.
error, probability of type
Yes,
alpha, beta. But what is p-value? So things like that, and not only matlab, they knew about how to explain it by giving example in clinical trials and all those things. So actually, I have to learn a lot of medical terms. So there, I used to sit with doctors to first learn some these medical terms, because I was not familiar with those medical terms. I bought this medical dictionary, doctor, and then I went through that and all those. Then I used to talk to them.
Okay,
So
sir,
this is
okay.
what they have to also do. I mean, it is both way actually. We should try to learn their language, their terminology, and they should try to learn our language. And the best thing is that जिसे कहते हैं मजा जब ही आता है ना, जब वो क्लिनिशियन हमारे स्टैटिस्टिकल रिजल्ट्स को खूब अच्छी तरह से क्लिनिकली इंटरप्रेट कर ले.
Yes, sir.
Yes, sir. Yes,
हमने
sir.
तो तमाम एक ही डेटा सेट की सैकड़ों तरह की एनालिसिस की, एक फिर सेकेंडरी, फिर एडवांस एनालिसिस, फिर एडवांस एनालिसिस. लेकिन उस एनालिसिस को कैसे इंटरप्रेट किया जाए, कैसे
Yes, sir.
कॉमन वे को कम्युनिकेट
sir.
किया जाए, वो एक आर्ट है. और वो इतनी जल्दी नहीं आती है, वो प्रैक्टिस से ही आती है.
Right.
Yes, sir. Or really, sir, personally, I feel that during the lecture, I was thinking कि सर जो है मेडिकल साइंस के प्रोफेसर हैं, लग ही नहीं रहा था कि आप ऐसे करेंगे.
सर मैथमेटिकल स्टैटिस्टिक्स के प्रोफेसर रहे हैं, डिपार्टमेंट ऑफ स्टैटिस्टिक्स हम लोग के.
Yeah, I know, but during the lecture, it was feeling again and again. Sir explaining the medical term in very well manners and very well explained. And at last, but not least, sir, really we are very grateful and we are very thankful to have such a wonderful resource person today. And sir, we will keep in touch you in future.
Okay.
And thanks a
Again,
lot,
I
sir.
thank you also for giving us me an opportunity to deliver this lecture.
Thank you so much, sir.
Sure,
Thank you so much,
sure,
sir. Thank you,
sure.
sir.
Sure, sir.
Thank you so much, sir.
Okay, beta, bye.